You are now listening to Nailed It, the Orthopedic Surgery Podcast. You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Hello, everybody, and welcome yet to another episode of the Nailed It Ortho podcast. Dr. Araiza, welcome to the show. I'm so happy to have you, and welcome to the podcast.
Thank you very much. Glad to be here.
Yeah, I've been looking forward to this talk. We briefly met during the course, the skeletal dynamics course out in Miami, and went through different approaches and stuff, and I really enjoyed that. So I'm super glad you are we're willing to come on the podcast and talk some more fractures and some more orthopedics. So again, welcome.
Thank you for having me. I'm honored, and I'm looking forward to, contributing to your audience. I'm excited about the folks that are listening, and hopefully we can spark good conversation for everyone.
Yeah, and Dr. Araiza, the first things that we typically like to do is just talk to our guests and get to know them a little bit better. And we know you do trauma, and you're a specialist in trauma. So what made you choose trauma out of all the different specialties?
That's a really good question. So the thing that I liked about trauma is that it brings me back to just what the general orthopedic surgeon used to be prior to all of the subspecialization that we have nowadays, right? In my clinic, you can see a 13-year-old pediatric patient with a broken elbow or unexplained knee pain in one room, and in the next room, you can see a 96-year-old lady who broke her hip and had to have either a replacement or a fixation of that injury. So that broad range of being able to take of pretty much everyone, and injuries from the sternoclavicular joint all the way through, toe injuries, it's just something that you can't really get in any other field. And I'm humbled to be able to do that on a daily basis.
Yeah, I think that's awesome, and definitely having a lot of different tools in your back pocket and being able to take care of all these different injuries is this, just like you said, it's kind of satisfying and rewarding. Another question I have for you is, looking back, is there any advice that you'd give yourself after just finishing up with fellowship? You've been in practice for a little while now. Any advice that you would give yourself? It could be about anything. It could be about the work itself or a lifestyle thing. But any advice, if you had to go back and give yourself or give others, what would you say?
So definitely, what I would say is learn to grade your outcomes, not just on your failures, but a lot on your successes as well. Unfortunately, in our field, a lot of times we're focused so much on what we could have done better to improve the care that we provided. And that's a good thing, and that's an honorable thing. But at times it can be a distractor that can take away from the things you've already done well. And, I just spoke yesterday actually to a former resident colleague of mine who just started out her practice. And, she had a very difficult first week where 1 out of her 10 cases just turned into this terrible ordeal where everything that she was attempting just wasn't responding the way that she wanted it to. And it really brought her down, and it brought down her spirit to the point where she was like, oh my God, what if I'm not ready? What if this isn't what I need to do? And I told her, I said, but what about the other 9 that went great? Like, those people matter too. And don't forget that, yes, you had one case that didn't go the way that you wanted it to. And of course it kicked your butt, and you're going to go read about it. You're going to go look at the x-rays. You're going to talk to your mentors and your colleagues about it. But the other 9 people that went relatively smooth, they matter as well. And you need to go back home and you need to, take your lumps and prepare to do better for the one outcome that you didn't have that wasn't as successful. But you also need to look at what you did well to make sure that you can replicate that in similar patients in the future. Because if you did something well and you don't take time to acknowledge it, to also learn from it and to implement it into your day-to-day practice, then you may miss on establishing good habits that can only help you in the future. So you have to have a good balance, to keep you sane and to keep you motivated with your practice. If you lose that balance, then it's a lot quicker for you to become, bitter or angry or even, sad about what you're doing, and you never should. I mean, orthopedics is a beautiful field. It's a fantastic opportunity to take care of people. We get to impact everyone's day-to-day living and their ability to live, and that's something that very few people get to do.
Yeah, I think that is a great piece of advice there. I know even me in my young age and a very limited training, and just started fourth year, have had kind of some of those similar thoughts. Like, I was doing a call, it was maybe 1 or 2 weekends ago, and had a couple of cases. You're chief on call, so you're doing, most of the cases, your attending is there as well, giving you tips and tricks. But I had some cases that went well, and then I had another case. It was a subtroch actually that took a lot longer than I expected, and I was kind of down, and I was, kind of doubting myself a little bit. And I really resonate with the fact that what you just said, you have to not only, learn from the mistakes of the case that didn't go well, but also from the cases that did go well. So I think that's a great tidbit. And last thing, we always talk about orthopedics and, a lot of things with orthopedics, but do you have any interest outside of orthopedics? Anything that you like to do? We just like to get to know our guests just a little bit better.
Yeah, absolutely. I love race cars.
Yeah.
I have one of the things that I treated myself to once I was an attending and got out of a little bit of debt, and when I passed boards, and to kind of just reward myself for the blessings in my life, I bought a Porsche GT4, which is a track car. It's not a car that you drive on the streets. It's a very uncomfortable car to get in and out of, but it's a bioengineering, just masterpiece. And so being able to get out on the track and being able to learn more about, the biomechanics of speed and of cars and stability and road grip and how to tackle a curve properly. You're constantly doing things to improve your speed by seconds, right? Or even by a tenth of a second to try to get that lap time to get a little bit better. It's great. It's a fantastic way to pass the time, and you do it in a safe environment. You're always checking your vehicle to make sure that it's up to date, that everything is safe. You wear your helmet, you wear your harness. And it's a really nice thing because it allows you to get away from some of the stresses of day-to-day practice and living, and to just, have something that keeps you human and keeps you honest, right? And you have to have that. We love to go on walks with our dogs. I like photography, so we like to go to nature and go on hikes and try to take as much photography as we can. My wife and I love that. So yeah, definitely the life work balance has to be there. Otherwise, it is quite difficult to stay strong and keep going.
Yeah, totally agree. And on that note, we'll go ahead and transition and get into the talk for today. We're talking a little bit more about subtroch femur fractures, and typically we go about history and physical exam, but we have prior episodes on femur fractures. If those listening want to go back and listen to that and learn a little bit more about what to questions to ask on patients as far as history and physical exams concerned. But what we always hear this term subtrochanteric femur fracture thrown around a lot, but what exactly is a subtrochanteric femur fracture?
Right. So by definition, a subtrochanteric fracture, those are proximal femur fractures, and they're located, from the lesser trochanter to at least, to at the most 5 centimeters distal to it. And they occur both in low energy, elderly patients, or high energy young patients mechanisms. But it's that, lesser troch to 5 centimeters from the lesser troch is by definition a subtrochanteric fracture.
Yeah, and what about these, these fractures make them different than, kind of just our normal femoral, diaphyseal femoral shaft fracture? Like, is there anything, or I guess the kind of the pathoanatomy of this subtrochanteric region in particular?
So the big difference are the amount of deforming forces that you have on the proximal fracture fragment. So you've got your gluteus medius and your gluteus minimus, right? And those are abducting that proximal fragment. You've got the iliopsoas, which is flexing that proximal fragment. You've got your short external rotators, which are, you know, uh, obviously externally rotating your femur. You're fighting those forces the entire time as you're trying to stabilize this fracture. And then your distal segment is being adducted, adducted, and shortened by your adductors. Your adductor magnus plays a big role in it. So you literally have four different groups of muscles that are inserting within that tiny little fracture fragment that are, that you're fighting against the entire time.
Yeah, and I know we'll get into it a little bit later, about how to counteract these deforming forces. But I know that's always like a test question, or at least a good pimp question that a lot of the attendings will ask, what the deforming forces are. And again, that's, abduction with abductors, external rotator with those external rotators on the proximal fragment, as well as flexion due to the iliopsoas. And then just like you said, for that distal fragment, it's going to be adducted and shortened due to the adductors. Now, are there any I was just reading up on this. There's some talk about these subtroch having sometimes having like, fracture characteristics. I know, at least in my very short limited time, when I've seen these, I've seen many of them. I've seen many disblasted and comminuted, some spiral. But in your experience, do any of these have any type of fracture characteristics that you need to know about?
In general, it depends, right? You can have your long oblique fracture fragments. Sometimes they're comminuted. Your atypical fractures, those are the ones that can be quite the challenge to fix. These are your fractures that are transverse fracture fragments. And this is where you start to talk about like what is an atypical fracture, right? And so by definition, there was a task force definition of an atypical femur fracture, and they talk about there's major criteria and there's minor criteria, and we can go over those just because they may pop up in a test question.
Yeah.
And so, but when you have your major criteria, they're talking about fractures that occur that are associated with no trauma or minimal trauma. So like a fall from standing height or less, right? So that's minimal trauma. You also have a fracture that originates from the lateral cortex, and you can see it by that lateral cortical thickening, and it's substantially transverse in its orientation. And again, a lot of these should either be, comminuted or long oblique fracture fragments. But if you have something that started out with that lateral cortical beaking or thickening, and then it all of a sudden turns into a transverse fracture pattern, then that's an atypical fracture there. These non-comminuted fractures, again, very challenging because without comminution, then now you go back to your basics of fracture fixation, right? Nails work fantastically because you take these comminuted fracture fragments and you stabilize them, and then you get that indirect bone healing, right, through that motion. Right. And the more comminution that you have, then the greater motion that you're able to develop, which allows you to, have that indirect, that secondary bone healing, that callus formation. But with these atypical fracture patterns, these aren't comminuted. And so, in non-comminuted fractures or simple fracture patterns, they love compression. And so then that's when it becomes a really challenging part of how do you get these essentially transverse fractures to become anatomic when you fix them, and for you to fix them in a fashion where they're still being compressed to allow you to get those to heal. So they can be quite difficult for those to heal at times. Then you've got that localized periosteal or endosteal thickening of the lateral cortex, so that's sometimes present at the fracture site. So those are kind of like your major criteria. As far as your minor criteria, you've got an increase in cortical thickness of the femoral diaphysis. That's something that happens. People will talk to you about these prodromal symptoms, right? They had dull or aching pain in the groin or the thigh that had been present for several weeks, 6 weeks, 7 weeks, 8 weeks. They went to get an x-ray. You know, the radiologist or the family medicine doctor or the ER doctor didn't pay close attention. They saw that there was no fracture. They missed that lateral cortical thickening, right? But they did have those prodromal symptoms upon presentation. You know, sometimes they have, if you have one atypical fracture, you better look at the other femur, because these can be associated with, bilateral incomplete fracture patterns. Then obviously you've got delayed fracture healing that can also occur. So, you know, that's in general. You know, if you don't have that simple spike or that simple comminuted or oblique fracture, and you see that transverse fracture pattern, you better be aware that you may be looking at an atypical fracture.
Yeah, and in these atypical fractures, are they most in your experience? Are they mostly associated? Because when they test us, or anytime I see them or ask about them, they always bring it up and they talk about kind of being in the setting of, you know, using bisphosphonates, or at least it being a more common thing with bisphosphonates when you see these. But is that how it is in your experience, or is there anything else that, you know, can kind of lead to these atypical femur fractures?
Yeah, no, absolutely. I mean, they're almost exclusively associated with bisphosphonate use of some sort at any point in time. And again, the characteristics that you're going to look at just on radiograph, you're going to see that lateral cortical thickening. You're going to see increased diaphyseal cortical thickness. It's going to be a transverse or short oblique fracture orientation. There's going to be no combination. There's also going to be a medial spike. So lateral thickening, medial spike, transverse orientation. You know, bisphosphonate use, very common. It's always in the same question.
Yeah. And are there any classification systems that you use for subtrochanteric femur fractures? I know reading up, I've saw some, but, you know, is there anything that you use or that you know of, or that are important?
So there's two. There's the Russell-Taylor classification, and then there's also the AOOTA classification. So for Russell-Taylor, fairly simple. It's the type 1 or type 2s. And, you know, and to just kind of keep it simple, your type 1s, there's no extension into the piriformis fossa. And your type 2s, there's extension into the greater trochanter with involvement of the piriformis fossa. And so, you know, what you want to do is you actually want to look at the lateral x-ray to identify whether or not there's that piriformis fossa extension. And that's really what one looks at. As far as the other classification, the AOOTA classification, so it's your 32A fractures. So there's 32A, 32B, 32C. And so, you know, your 32A fractures are your simple transverse subtrochanteric fractures. Your 32Bs are your wedge fragmented subtrochanteric fractures. And then your 32Cs, as you know from the AOTA classification, now we're getting into the more complex, you know, spiral type of fractures.
Right. And why is that important if these fractures extend into the piriformis fossa? You know, is this something that you can open up and clamp and then try to get a starting point over that? Or what's the importance of it extending into the piriformis fossa?
Well, it may eliminate your ability to get what's known as an on-axis starting point if you're thinking about fixing it with an antegrade femoral nail. You know, these fractures, if you have these fractures that don't extend into the piriformis fossa, then we could talk about tips and tricks. But in general, what you have is a proximal femur shaft fracture, and you know, and in those fracture patterns, then the best for reduction, the best for fixation is to maximize the amount of compression that you're going to have from your proximal fragment to your distal fragment. And the best way to do that is by having an on-axis nail that can fix that. It's also going to essentially do the reduction for you. But when you have extension into the piriformis fossa, now you may need to change your means of fixation. Now, instead of going on axis, with your femur. Now you may have to go off axis. And and if it goes into the piriformis fossa and maybe even involves the base of the femoral neck, then now you change your complete implant choice as well, because you may need to do a proximal femur plate to be able to stabilize that base of the neck area, or do an off-axis cephalomedullary nail type of implant to be able to stabilize that basicervical fracture pattern, along with that subtrochanteric proximal femur fracture pattern. So your fixation will completely depend on whether or not that fracture line extends into the piriformis fossa.
Okay, makes total sense, and we'll get into kind of some of the operative tips and tricks here in a bit. But say, for example, you get this patient, or say you have some residents with you and they call you and they say, this patient here, they're 35-year-old male involved in a high motor vehicle collision, finally had the subtrochanteric femur fracture. What is your acute management in the ED? I know where we are, we tend to put these patients in skeletal traction, but is that something that you do, or what would be your emergency department management, acute care?
So skeletal traction is great for symptom management. And the reason why is because it's the best form of a muscle relaxer that you can give a patient. And I didn't understand that until I got into practice, and I did it long enough that I realized, that people actually feel better when you put them in traction. And it's simply because the muscles finally just tire out. And there is a massive amount of pain that occurs in these folks because of the deforming forces. And those muscles just keep pulling and pulling and pulling on those fracture patterns. They keep continuing to cause inflammation, muscle edema, not to mention the fact that you can have further oozing from that medullary canal into the surrounding tissues. Now you've got an expanding hematoma, which can compress some of the nerves, and again, to lead to some further downfield effects. And so whenever you put someone in skeletal traction, then now you're allowing for those muscles to relax. You're allowing for that bone to become more on axis than it was at the time of the injury. You're minimizing soft tissue trauma, which is important as far as fracture healing is concerned. We know that soft tissue handling and management of soft tissue is incredibly important to fracture healing. And so all of these things can be accomplished with a skeletal traction. I typically tend to do this for people who are younger. So your younger males or females who were involved in a high-speed motor vehicle accident, or maybe a fall from height. I don't do them in the elderly, even in subtrochanteric fracture patterns. And, there was a really good study that was published by, the AAOS, where essentially they looked at our clinical practice guidelines for the management of hip fractures in the elderly. And, when they looked at all of the studies that were out there, there was no difference as far as pain levels are concerned in geriatric patients with hip fractures, whether they went into traction or no traction. So typically, if I'm going to do anything on a geriatric patient overnight, if they're really uncomfortable, I'll put them in bucks traction with about 5 to 10 pounds at the most, never more than that. If they're comfortable, I leave them as is.
Okay. And so say, we've have our patient, they're in some type of traction, or maybe even not if they're, elderly patient. Are there any patients that you undergo non-operative treatment for with these subtrochanterics? And if there are, what is that treatment?
So non-operative, treatment is typically reserved for non-ambulatory patients with medical comorbidities that would not allow them to tolerate surgery. And it's very limited role. Again, secondary to those muscular forces that are constantly deforming those fracture patterns, those fracture fragments. And it's also the inability to mobilize these folks without the surgical intervention. So it's incredibly rare, and it typically is reserved. It's only reserved for hospice end of life patients that, to me, are either demented and no longer demonstrate the ability to feel pain, or the risk is so great that any kind of anesthetic would lead to a major intraoperative complication. And so those folks, we end up getting them, on hospice because we know the pain from the injury is going to be so great that they're going to have a pretty high mortality rate anyway. So we want to get those folks in, as comfortable as possible.
Okay. And so, that's kind of the non-op treatment. So what are some of the, I guess we can kind of go just broad, what are some of the general operative treatment options? And then we can kind of go more specific and break some things down. But in general, what are some of the ways to treat these subtrochanteric femur fractures?
So you can nail these fractures or you can plate these fractures. So nailing is kind of the standard of care. Now, I think it's always important for medical students, residents, fellows, and early career surgeons to understand that there legitimately is a difference between a cephalomedullary nail and a reconstruction nail. And oftentimes when I see fractures that fail, it's because the treating surgeon didn't know what the difference was between the two nails and what they're meant to be used for. So when you have a fracture that is subtrochanteric to distal, that fracture can be treated with just an intramedullary nail. And it's just an antegrade nail that has a proximal interlocking screw. It can go into the lesser trochanter. It can go, an oblique orientation across the trochanters, or it can go into the femoral neck if you want to. You can have one going into the femoral neck, one going into the subtrochanteric region. A reconstruction nail, simply in my hands, and what it does is it's just a nail with proximal interlocking screws, and then the distal interlocking screws obviously are put in with your perfect circle technique or your targeter if you must. A cephalomedullary nail, by definition, you are trying to get compression across that femoral head. So that is more of your nails that have a lag screw or a helical blade or a screw or a two screw construct into the head. And there is some sort of compression that occurs across the base of the femoral neck with that screw. Okay. And so this is again going back to the fracture patterns, your type 1s versus your type 2s. If you have a fracture that doesn't go into the piriformis fossa, then you need to fix that with a reconstruction type of nail or an antegrade nail, period. If you have a fracture that extends into the piriformis fossa, then now you must get compression across that piriformis fossa. You must compress that, additional fracture line. And you can only do that with a cephalomedullary nail. You have to have something that has a lag screw that goes into that femoral head and neck that is going to compress across the base of the neck to allow for that fracture line to heal. I've seen some of these fractures that are treated with reconstruction nails and they end up failing. Why? Because those quote unquote lag screws that are placed through that reconstruction nail, they don't provide enough force or enough strength to be able to compress across the base of that femoral neck. And so you really want to make sure that you use the correct nail for the correct fracture pattern. If for whatever reason you don't feel like you can safely nail this proximal femur fracture, and we did, and we published a study in JOT a couple of years out of Wake Forest where we looked at proximal nailing of femur fractures, proximal plating of femur fractures, and we discussed on there that in certain fracture patterns where you don't have the ability to contain the nail within the femur itself, it is acceptable to plate these fractures, but the principles still apply. Whether you use a blade plate or whether you use a proximal femur plate, you had to respect the soft tissues, you had to respect the biology. So what we recommended was, minimal dissection across the fracture lines, essentially making a small incision at the level of the vastus lateralis to create this kind of channel that allows you to slide your plate underneath, distally. And then you can make sure that you get that fracture well reduced, you get it in a nice valgus position, and then you can stabilize it with that fixed angle device into the proximal femur so that you're allowing for constant compression across the subtrochanteric region throughout its healing.
Okay. And so kind of to summarize what you were just saying, right? So when we're thinking about nailing and different types of nails, and we think about the fracture orientation. So if we have just a subtrochanteric femur fracture where you do not have extension into, let's say, the piriformis fossa, we can use what's called a reconstruction nail, which is pretty much just two locking screws that go into the femoral head, or through the neck into the femoral head. Versus if we have a fracture that as a subtrochanteric that actually extends into the piriformis fossa, now we need something that'll give us some compression over that fracture line that's going into the piriformis fossa. So instead of these screws that are interlocking screws that don't give you any compression, you would use some type of a construct where you have a lag screw, or you use a blade plate, not a blade plate, I'm sorry, or you use a blade, like blanking on
the helical blade.
Yeah, the helical blade. So you either use like a helical blade or a lag screw or some type of construct that gives you compression through that fracture line. So those are the two different categories. So just our reconstruction nail is literally just two interlocking screws, just like when we have our distal screws that we do, just like you're saying with the perfect circles technique. Those are just interlocking screws, no compression over that.
They really are. And I think, like, if you had non-displaced femoral neck fracture, or even a non-displaced, hard to tell line across the base of the femoral neck, yeah, you could put the two lag screws, but again, they're not going to lock into the plate, and then and you're also not getting tremendous compression either across that femoral neck, and so whereas when you use a cephalomedullary nail, by definition, that lag screw is compressing the minute from that femoral head through the neck all the way across the base of the neck. So if you need added compression across the proximal femur, not just the proximal femur shaft, then you want to use a cephalomedullary nail construct. If you just need to stabilize the proximal femur for both fixation and also rotation, then a reconstruction nail allows you to do that. And the nice thing about it is these reconstruction screws that you're putting into the femoral head and neck are obviously smaller. You're taking out less bone from the femoral neck and head, lower profile, and certainly can cause less damage to the endostheum of the bone than a lag screw would in an area that's not broken.
And then on the contrary, so I remember one of a lot of things I had trouble with is I'd sit here and I'd be like, oh, I think that probably use some reconstruction, recon nails I would use, and I tend to be like, I think I'll put a blade plate in that. So what again would be the reason why you're looking at a fraction? You'll say, okay, that is one I think that could be better used with a plate versus a nail.
If there's no, if the entire piriformis fossa is completely comminuted, maybe if you have a lateral wall blowout, posterior wall blowout of the proximal femur, and you think that you're just going to, you're going to slide a nail into this empty space, and sure, you can put a lag screw through the nail into the femoral head, and you'll compress that femoral head and neck into the nail. But if there's no basal cervical area, if there's no pertrochanteric area for that nail to squeeze, for that lag screw to squeeze into, then that fracture is going to have a really hard time healing. When you use a blade plate or a proximal femur plate, locking plate construct, you're doing it in an area where you really need to push all of that lateral femur medially. So rather than putting cables around the femur, like you might have to get that nail to kind of hold within the canal, instead you're going to use the plate to push everything medially. You're pushing the lateral femur, you're pushing the posterior medial femur, you're pushing it medially against the base of that neck, and then you're going to hold it there with these fixed angle screws or this fixed angle device, and then you're going to lock it, distally to the femur, not with locking screws. You're going to use non-locking screws so that you can then compress that proximal femur fracture fragment that you just fixed with those fixed angle devices to the distal fragments.
Ah, okay. Yeah, that makes definitely makes a little bit more sense now. That's something that I always was wondering back in the day. And I know we're going back and forth, but back to nailing. If we're trying to choose a start point, any thoughts on the different start points and why you would choose one versus another if you're thinking of using an antegrade femoral nail to treat a subtrochanteric femur fracture?
Yes. So if you have an extra-articular fracture, and or type A doesn't involve the piriformis fossa, using an on-axis and inline starting point through the piriformis fossa will help you reduce the proximal fracture fragment, and then also minimize the likelihood that you're going to go into a varus malreduction. And sometimes even, a flexion malreduction as well, because again, you really control the entire proximal femur through a piriformis access point. Unfortunately, there are some times when patients are really morbidly obese or really muscular, and you're not able to get a piriformis starting point. And in that point, then you have to do an off-axis or greater trochanteric entry. That doesn't mean that you should ignore the principles of fixation. And those folks, you need to think about, okay, how can I control that proximal femur fragment? And one thing that you can do is you can use a shank spin and just put it into the most distal aspect of the proximal femur, and just use that to help you control that proximal femur, so that then you can get the perfect antegrade starting point. So you can use a shank spin from lateral to medial. Certainly you can use clamps as well to help you kind of compress the proximal to distal fracture fragments. Pelvic clamps are great for this. They do a fantastic job of helping you reduce that. If you have a long spiral fracture fragment, you can use a collinear reduction clamp. It does wonderful. It's minimally invasive. You can do it through small incisions, and it's a relatively safe reduction aid to use. And then large Webers as well. You can use the proximal, you can use the proximal tine and really dig into the greater trochanter, and then make some small pilot holes into the distal segment if necessary, and then compress from proximal to distal. Again, you're taking those forces and you're turning them into tension forces by using those clamps, and then that can straighten out your femur and allow you to get that on-axis starting point. Now, you have to be careful if you have to go off-axis. So if you have to do a greater trochanteric entry point, then the placement of your clamps becomes incredibly crucial, because oftentimes what you'll find is that you end up putting your clamps right over the greater trochanter, and then now you don't have access to that starting point, right? So if you're going to use clamps to reduce your fracture, then do so understanding that hopefully you can do a piriformis entry point. If you cannot do a piriformis entry point and you have to do, an off-axis point, then you can still do it, but you just need to place your clamps a little bit more distal to the greater trochanter, so that way they're not in your way when you are getting that entry point, and most importantly, when you're reaming as well.
Okay, so in many of these cases, do you attempt to close reduction, and if you can't do that, do you just go ahead and open it up and then use one of those tactics that we're just talking about? You can try to reduce it with a Weber clamp, or use a shank spin from lateral to medial posteriorly to the nail, and try to manipulate that fragment so you can get your starting point, Or is that what is just kind of your sequence of events, or are you saying, like, if you're going to use a reconstruction nail and you're going to have to make an incision anyways to put 2 screws up, do you just go ahead and make that incision and clamp it from the get-go?
So I used to try to do these in a closed fashion when I first started, and then I realized it never works. It just doesn't. And so I very quickly let go of that, almost like like a pride factor.
Yeah.
And then I realized these are not going to go on the Hannah or your fracture table, because no matter how hard you pull through that fracture, you're still not going to be able to correct that proximal flexion, and then also external rotation and abduction, right? And in fact, sometimes it's even harder to correct that deformity on the fracture table. And then you end up opening them and making even a bigger incision so that you can get a cob along the front of the femur so you can correct the flexion, a ball spike pusher, along the lateral aspect of the femur so that you can correct the external rotation and the abduction. And then through the distal segment, now you have to put a cob underneath it so that you can correct that extension of the distal segment and so that you can bring it more into flexion. So doing that is quite difficult if you don't have a lot of hands. And also you're fighting the real estate. Either you make a big, massive incision, or if you're trying to do this in a soft tissue friendly fashion, then it can be quite a disaster. So all of these folks are lateral on a flat table for me, whether that's a Jackson table or any kind of radiolucent table. It is fantastic. It helps you right off the bat. You essentially take out the adductors, right? We talked about the adductors are a big deforming force. So the minute you put them lateral, you already took them out. Be prepared immediately to have an extra bump of towels that you can put, right underneath the thigh as well, because that'll help take the adductors away even more. And then also, it's a lot easier to pull on the leg and to get that inline traction. And it's also a lot easier to correct some of that abduction of the proximal fracture fragment, because you're looking at it, you're staring at it, you can make a smaller incision and immediately push down on it with a ball spike pusher. But I always open these. What I like to do is, before I even look at, how I'm going to nail this fracture, I look at how am I going to reduce this fracture. So these people are lateral on a flat table, radiolucent table for me. I bring in the C-arm immediately to the lateral rather than going to the AP, and I mark out how flexed is my anterior, how flexed is my proximal fragment, and how extended is my distal fragment. And then I kind of pick the middle line and I say, okay, this femur should be going across in this direction. So I mark out my incision where I think the femur should go. Then I make a nice dissection down to the fascia. I identify the vastus, and then I go underneath the vastus. It's always a nice subvastus approach. I try to preserve as many of the vessels as I can and coag the ones that are in the way, your perforators. And then I put a blunt, cob along the front and along the back of the femurs. And then at that point in time, if it's a spiral oblique fracture pattern, then, like I said, I try to clamp it with either a large lobster clamp or maybe a collinear clamp. It does great for this. If it's a very comminuted fracture fragment, then certainly you can consider using Shands pins, one in the proximal fragment, one in the most distal one, and then just using maybe even a universal distractor to kind of help you get it out to length and correct it. The proximal femur, you can correct the extension by putting a cob along the front of the femur and using that to correct that flexion. And again, the abduction, you can correct it by just using a ball spike. You're staring at it, so you can push straight down, and that corrects that segment. And then I try to hold that reduction somehow, right? And again, clamp placement then becomes key. And then once we have all that, then now I tell myself, okay, is this truly a subtrochanteric fracture without extension into the piriformis fossa? If it is, I try to get my piriformis entry point, and then If it's something that I feel is more comminuted, it may extend into the proximal piriformis fossa, then I just go for an off access point.
Okay. And okay, so you start off, we'll take a second, go back to the approach. So when you do your approach, just a technical tip, just technical question is because I'm wondering, because I'm doing them now. When you're doing your subvastus approach, you're trying to kind of go right underneath the vastus lateralis. Do you use a cob to kind of clear that off? Or I know you said you use a cob and you put it, over the anterior and posterior femur, but anything, or you just use your finger and just feel underneath and then just try to put a Homan or something underneath there?
Yeah, so make your incision, get nice, cauterization, hemostasis down to the level of the fascia. And then I don't put any retractors to the, until I get to the fascia. Again, you want to minimize, the stripping. Essentially what you want to do as a surgeon is you want to stop creating your own Morel-Lavale lesions. Stop devascularizing the subcutaneous fat from the fascia. That's something that's hard to understand and to visualize, particularly in morbidly obese people. But a lot of your subcutaneous fluid collections that eventually become infected are going to come because you just went down, made your skin incision and immediately started stripping all the fat away. And all you did was just create a Morel lesion. So you don't want to do that. You want to make a nice full thickness dissection down to the fat, and then you can clear off just the area that you're going to incise a little bit with a Cobb elevator. You make your incision, and then at this point in time, just like if you were going to do a hip arthroplasty procedure, you take the fascia and you retract it anterior and posterior to the femur, and you could do that with self-retaining retractors, and you're not going to hurt the skin because they're deep to the fascia. At this point, then what you do is you feel kind of that proximal, vastus ridge there, and then you can make a nice little incision along the proximal aspect. So you go from anterior to posterior, and then you can elevate the vastus in that fashion. So then you just take a Cobb and you just bluntly start to elevate it from posterior to anterior until you see what you need to see. And then right. you hold those proximal fracture fragments and your exposure with just some blunt Homans. Always use blunt Homans around here. I don't like using sharp Homans. A lot of people, they do like using your Cobra type of retractors. But you got to be careful because not every Cobra retractor is blunt. Some of them are fairly sharp, and you have a lot of vessels around the medial side of that femur there that can be quite difficult to control if you just go in there and kind of lacerate those from the contralateral side. So once you get your blunt retractors along the medial, the anterior and posterior aspect of the femur, then you can do a lot of work. A good kind of tip that I learned, a lot of your hip pans for total hip arthroplasty, they have these carbon fiber radiolucent retractors. So one thing that you can do is find out at your institution which sets those radiolucent carbon fiber retractors are located in, and just tell them like, okay, which set are those in? And for these femurs, for these fractures, I always have them bring those retractors up because you can leave those in place when you bring your C-arm in to see how your reduction is going without having to take them out and without having to find your exposure all the time.
Okay. And so, like you said, you went down, you did your exposure, you exposed the fracture site. You said if it's kind of those long oblique ones, you may use a point-to-point or a Weber clamp to see if you can get your reduction. If it's one that's a little bit more comminuted, tips and tricks you had for that would be to use a Shantz pin, put it from lateral to medial to help you control that proximal fragment. You mentioned a little bit earlier about possibly, using a like a 2.5 drill bit or something and making a drill hole distally and then putting a clamp over the greater trochanter and then using that drill hole to place the other clamp. You can compress through that. You talked about using a linear bone reduction clamp. And then other tips, just to reiterate, I think that you said, is to help get rid of the flexion of the proximal fragment from the iliopsoas. You can use a Cobb and try to push that down, and to help get rid of that abduction from our abductors on the proximal femur, you can use a ball spike pusher and push that in. And then once you got that, kind of clamp and see what you can get from there. Now, do you ever use a little provisional plate for any time, and you just put some unicortical screws in?
Yes, if they're really comminuted. And if I'm able to use an on-access piriformis entry point. And in fact, that's one of the best things that you can do. In fracture surgery, I always ask myself, like, can I divide a bone or a segment into three columns, a medial, intermediate, and a lateral column? And so if you're looking at a proximal femur and you have this massive amount of medial, posterior medial comminution, and then you have just a tiny little cortical contact laterally, well, that may not be enough to really support your entire fixation construct. And so by putting on just a tiny provisional, unicortical plate with some 12 millimeter locking screws, you actually reestablish your lateral column so that your nail will then become your intermediate and your medial column, essentially, of that proximal femur, and it'll increase significantly the stability of your construct to allow for that fracture to hopefully have more fixation, likelihoods and healing as well. So and we don't take it out. Again, that is not going to prevent. It's a small, it's a small fixation construct with tiny little unicortical locking screws. They're going to hold your reduction for you. They are not going to prevent that micro motion that nail is going to try to do for you. So definitely you don't have to take it out. It's a reduction aid, and just think of it as a permanent clamp that's staying there holding your reduction so that your nail can do the rest of the work for you.
Okay. And one more thing, or at least one more thing to touch up on before we wrap up here, is do you have any tips as far as when you're reaming or getting an entry point? Some of the things that I was reading, kind of just preparing for this talk and preparing for cases in general, is with the piriformis entry, it was saying you could start it just slightly more anterior and try and medialize the reamer. Can you kind of talk about what they're getting at with this information, or like kind of what some things we need to know about reaming and I guess nailing these?
Yeah, so you're never going to ream more medial than your guide pin is at. So that's one thing that you want to learn right off the bat, is that by definition, as you're reaming your natural tendency, and you're kind of forcing the reamer, if it's a really tight canal or if it's a really morbidly obese patient, you're forcing them always from the outside, of the body or away from the body towards the body. So you're always, leveraging that reamer against the lateral femur. And so, if your whole concept of trying to do an on-access or a piriformis nail is to be, in line with the femur, well, then the last thing that you want to do is turn that piriformis entry into a greater trochanteric entry, right? So starting, like we talked about, a little bit more anterior helps you because it's also going to prevent you from going a little bit more lateral as well. So that's one good thing. Also, putting your screws into the head. Most of the time, you'll find that you're getting into the posterior medial aspect of the femoral neck as you're going into the head. And so when they talk about starting just slightly a little bit more anterior, that'll help you get those screws into the femoral head and neck into a more center position. Medializing the reamer to prevent eccentric reaming, again, that talks about how you're always going to come more lateral than you think you're going. If you find yourself that, like, man, something's not right, I started out reaming more medial than I'm currently at, then one thing you can do is you can take a cob and put it and slide it over the lateral aspect of the hole that you've been reaming, and then use that as your new lateral window so that you can force yourself to ream again more medially. So even if we make the mistake, because I've done it myself, of all of a sudden reaming eccentrically because now I'm a little bit more lateral than I started, then before I put my nail down, and even when I put my nail down, I'll take a cob and I'll use it to push my guide wire medially. And then I'll know that as I ream again and as I pass my nail down, that cob will keep me down the center of where I've started and not where I became eccentrically. And then again, I think, one of the things we're talking about, tips to prevent the guide wire from going medial, if there's an oblique split present. Really, what should matter there is more than anything realizing that do you have the correct starting point, right? If you have an oblique, fracture line present, then you really should be doing an off-axis entry point. You shouldn't be doing an on-axis or piriformis entry point. And so that's one of the things that can help you from going into that fracture line, is by making sure that you're starting at the correct point.
I think that was great and excellent. And just to further explain, when we're talking about, reaming, we're talking about when we're putting it in, because when I was thinking about it, I thought I kept thinking about the distal part of the reamer, but what we're talking about is when we're reaming and we're starting it, and the wire seems to drift more and more laterally, that with the reamer you start to take out more and more of the lateral, like that lateral circle, I guess you could say, and that is what would cause more of a varus deformity if you continue to do that. Because once you start to, instead of it being a straight line, it starts to be a curved line, and once you implant a straight implant, it'll go into varus, if that makes sense. At least for those listening to this, you may have to look up some pictures and picture in your head, but that's kind of one of the things that took me a while to figure out. That's what we were talking about when we were talking about this.
It does. And when you're going into varus, you're going into varus because you malreduced the proximal segment.
Yeah.
And so that's the thing you can't do. You have to minimize the likelihood of that happening at all costs. The other thing too to keep in mind as far as distally is making sure that before you ever start to ream, you take a really good perfect AP and a really good lateral of your distal femur to ensure that your guide wire is in the center position. And more than anything, you have to remember that very few nails will actually match the radius of curvature of the femurs that we're dealing with. And so therefore, what I try to do is I take my ball tape guide rod and I actually try to put it into the lower third of the femur on the lateral, because I know it's not going to end up that way. If anything, it's going to end up a little bit middle third to upper third. But I definitely don't want it to come out the anterior aspect of the femur, and we know that's a common mistake that's done. And so, therefore, if you bury that guide wire into that lower third on the lateral, then that's going to essentially protect you, to the best of the ability. And the other thing too, whenever you bury it into the distal third, the inferior third of the lateral femur, you get into some nice, almost subchondral bone that prevents you from migrating anteriorly. So definitely do that. Other tips that I've learned, if you have an empty, if you're nailing someone who has really osteoporotic bone, you can put a blocking guide wire distally, a drill bit. And just, if you're thinking you're migrating too medially with your reaming, stop what you're doing, bring your guide wire back, and decrease the size of that medullary canal. Make a small little incision, see where your guide wire is going. Put a drill bit that you're going to use for your distal interlocks, and just go from A to P exactly in that orientation. And then now your guide wire is going to go lateral to that, and it's going to keep you from migrating too medially distally. As you re-ream, you just have to make sure that you re-ream through your new path, so that way your nail will know where to go. Every company has a long finger reduction tool. Every company, regardless of who they are. So you have to ask them to make sure that they have it available. Most of these are, 8 to 9 millimeters in diameter. You can ask your rep, what is the diameter of the shaft of your long finger reduction tool? Because you can use that to your advantage. If the ball tip guide rod isn't going where you want it to be, then use your long finger reduction tool and then just almost oscillate all the way down to the femur, so that then you can decrease the distance that your ball tip guide rod has to travel, by just, shortening it, where it just has to go from the end of your finger reduction tool to the end of the femur. And you can control that obviously by putting about a 10 to 15 degree bend into your ball tip guide rod distally. So those are some of the things that can help you make sure that you're reaming properly and that you can really control the path of that femur. The femur will not, do the reduction for you the way that you ream it, and the way that the nail will not do the reduction for you. And it might seem contrary, because you might say, well, Dr. Araiza, you just told me that doing a piriformis entry nail, will reduce the femur for me. No, it's your reaming will reduce that fracture for you. Your finger reduction tool will reduce that fracture for you if you actually get the correct starting point and you don't malreduce it. But you have to remember that the nail is just the conclusion of everything that you've done before that point.
Right. And I think that's super important. I think those are all great tips and tidbits as far as the technical aspects of this case. And I know you could have a whole podcast episode on the complications from subtrokes, but just really quickly, do you mind just kind of touching on some of the big complications from subtrokes that we see after we nail these?
Right. So, improper reduction from the starting point. Again, that's a big deal. You can go into varus inflection malreduction, commonly seen when these are done on a fracture table, because it's quite difficult to correct those deforming forces. And again, you get that nail down that improperly reamed path, and it's going to stay improperly reduced. And then non-union certainly can happen. It's something that is seen particularly with your atypical fractures, right? And it's seen again because rather than having that comminution that increases your surface area for secondary bone healing, you have these relatively simple fracture patterns. And if you did not reduce this anatomically and you are not compressing across that fracture line, it is very unlikely to heal. And so you may need to do either exchange nailing or maybe do, a fixed angle plate with or without bone grafting. These are the only femurs that I will actually dynamically lock distally, so allow them to start compressing the minute that they walk. Most of the time, we statically lock them because obviously we don't want to change the length of them. But by definition, a transverse femur fracture is a stable fracture pattern. So if you dynamically lock them, then that tiny little amount of that 1 centimeter of compression can certainly help them in those atypical fracture patterns if it's necessary, if you think you need it.
Well, excellent. I think Dr. Araiza, I think this was a great podcast, great talk. I know I learned a bunch just from talking to you and hearing some of your different tips and tricks. We touched on the deforming forces, we touched on pathoanatomy, we touched on the management, we touched on the approach, we touched on reduction tools, tips, tricks, talked on about the different types of nails, one to kind of some broad characteristics of one to nail versus one to plate. So I think this was really good. Anything else that you think you want the listeners to get out of this after listening to this podcast before we wrap up?
Yeah, I think I want listeners to understand that these are complex femur fractures, and that it is important to not take these as your regular femur shaft fractures that that you're going to go in and possibly do in just 30 minutes. Don't be afraid to ask for a Foley so that you don't get into a situation where you're 2 hours in and your nurse is asking you how much longer because we forgot to put a Foley in. Treat these fractures. Yeah, treat these fractures as though you're going to open. So make sure that you have good access. Your anesthesiologist should have, good access for infusion of any kind of blood products as necessary. Know the resuscitation status of your patient and whether or not they can tolerate a long open procedure where you can have 500 to a liter of blood loss. Make sure that you've studied the pre-procedure CT scan well so that you can know whether or not you can do an on-axis nail versus if you need to go off-axis. And then also make sure that you know whether or not you need to compress across the base of that femoral neck, or whether you can do it with just rotation screws, which is what the recon screws are. Use your radiolucent retractors if you have access to them. Make sure that you have in the room available Shands pins, even if you don't open them, that you have large fracture reduction clamps, Weber's collinear clamps in the room, even if you don't use them. And most importantly, always ask for more paralysis than the CRNA or anesthesiologist wants to give you. Even if they say, I just checked it, there are no twitches, you know how tense those muscles are. You can tell them, we're going to be here for another hour to an hour and a half. You need to give more paralysis. They will never give enough to get them to relax to the point where you can do this. And so, those are the things that can make your life a lot easier, that can make the case be smoother for your patient and for yourself, and to allow you to do a safe, efficient surgery.
Perfect, Dr. Araiza. I think that was great. Great tricks and tidbits and high points to touch base on. Again, I think this was great. I want to thank you again for coming on the podcast, being a guest. At the end, we always let our guests, share if you have any social media or anything that you want people to follow you on. Feel free to let the people know. If not, that's great, but totally up to you.
Yeah, thank you for allowing me to do that. So I do have an Instagram account. It's ortho_trauma_Texas. And so, what I like to do is I like to just post cases and x-rays that I've done. And the nice thing about, the cases that I like to post is that they're principle based. You'll find a lot of surgeons that are just masters at surgery, and they'll post some of these incredibly complex cases that only they could do in their hands. And I think that's a fantastic learning tool for everybody. And I certainly follow a lot of those people. I like to tailor my cases more towards something that everybody can do. The general surgeon, the hand surgeon who's on call, the trauma surgeon who's on call, because I think that it's more usable to the entire community if it's something that not only a fellowship trained trauma surgeon can do. So certainly, I think you guys will find that. And then also you can send me messages there, and we can talk shop about any cases that you may be preparing for that we can discuss to kind of help spark some communication. And certainly I'm always available to anybody that's interested in orthopedics and orthopedic trauma, or just wants to talk ortho in general. Even if it's something that's different, right? Like if you guys ever want to talk about how do you code, how do you bill, management of the operating room, staff, your nurses, your PAs, your medical assistants. So there's a lot of things outside of the operating room that matter significantly to your day-to-day practice. And so the more that we're involved with each other in the community, the better that it is for everyone.
Perfect. Well, Dr. Araiza, again, thanks so much for coming on to the podcast. Those of you listening, we hope you enjoyed this episode. Please don't forget to hit that subscribe button and stay in tune for the next week's podcast. But then again, go and leave a review and let us know how much you like this podcast and this talk today on subtrochanteric femur fractures. Until next time.